Welcome to the Hospital Medicine Unplugged podcast.
Great to be diving into this topic today.
Indeed. Today, we are undertaking a really critical deep dive into one of the most common, yet I think we'd agree, highest stakes electrolyte disorders we face in the inpatient setting, hypernatremia.
It really is a paramount topic for hospital clinicians. Hypernatremia, we define that as a serum sodium concentration exceeding, 145 millimoles per liter. It's a lab finding we see all the time.
Daily.
Yeah, daily.
Yeah.
But its clinical implications are, well, sometimes minimized, or maybe the management protocols get applied a bit too rigidly. They don't always account for chronicity.
Absolutely. And that's really our mission today, isn't it? It's highly focused. We need to move beyond just the definition. We want to distill the latest evidence about the, frankly, surprisingly severe morbidity and mortality tied to this and clarify those key diagnostic points like urine osmolality, that's a big one, and synthesize the data on safe fluid selection and, importantly, those customized correction rates. We really have to nail down the difference between correcting, say, acute, often iatrogenic sodium overload versus that chronic free water deficit picture.
We really must start by establishing just how severe this can be. Hypernatremia is, it's far from benign.
Right.
Its prevalence is startlingly high, especially in populations where those regulatory mechanisms might be compromised. We see this a lot in older adults, nursing home residents, people with cognitive impairment or restricted mobility, those dependent on others for hydration.
And the data from high acuity settings like the ICU, it's pretty sobering, isn't it?
It is.
We know the incidence there can reach up to, 27%? That's alarming.
It really is. And it's not just a lab value quirk. It often reflects a systemic failure, to balance fluid homeostasis in these critically ill patients.
Precisely. And that high prevalence, it translates directly into some pretty devastating outcomes. The literature seems unanimous on this.
It does. Hypernatremia is associated with really profound morbidity. It can lead to new or worsening delirium, increased risk of falls, and just an overall loss of functional independence for the patient.
But the number that should truly get our attention, maybe drive protocol changes, is the mortality rate.
Yeah.
In severe cases, the in-hospital and post-discharge mortality often lands somewhere between 30% and 40%. That's huge.
It's staggering. It's comparable to many severe systemic infections or, major organ failures.
It's an independent predictor too, right? Even modest elevations, just creeping above that 145 millimoles per liter mark, are linked to increased length of stay.
And critically for the survivors, a much higher likelihood of discharge to long-term residential care instead of going home.
That's a major functional setback. It really underscores why prevention and then prompt, tailored management are just essential for the patient's long-term path.
Absolutely.
Okay, so let's unpack the underlying mechanisms a bit. When we look at the pathophysiology, what's the core issue driving this imbalance? And maybe more importantly for us as clinicians, what are the failures in the patient's own defense system that let this happen in the hospital?
Well, at the most fundamental level, hypernatremia always signals a state of hypertonic hyperosmolality.
Okay.
So basically, the concentration of solutes relative to water is just too high. This happens either from a net loss of free water, and that's really the dominant cause in our hospitalized patients.
Right.
Or, less commonly, it's a net gain of sodium relative to the total body water.
And that physiological defense system you mentioned, thirst, arginine vasopressin AVP secretion, and the kidney's concentrating ability, that all has to be working properly to keep plasma sodium in check. Why does that system break down so often in our inpatients?
Several reasons, really. The most frequent cause we encounter is just a pure water deficit, usually due to not enough intake. Patients are often MPO for procedures, or maybe they have impaired thirst mechanisms from age, dementia, stroke.
They just can't signal it or get water themselves.
Exactly. They can't signal their need or physically access water. The AVP axis might be working fine, but if the patient can't respond to thirst, that defense is effectively neutralized.
Let's focus then on those inpatient-specific risk factors, the ones often labeled iatrogenic or maybe systemic vulnerabilities that we as clinicians might actually be able to control or prevent.
Yes, and we have to be really vigilant here because prevention is so much better than correction.
Definitely.
First and simplest is just inadequate free water administration in NPO patients. Insensible losses from the lungs and skin, they continue. And if the IV fluids provided are isotonic or maybe even slightly hypertonic, well, that patient is almost guaranteed to drift into hypernatremia over time.
And we also see significant losses driven by medications, right? Excessive diuretic use, especially loop diuretics, seems to really accelerate renal water loss.
That's right. Loop diuretics, they impair the kidney's ability to concentrate urine in the thick ascending limb. So essentially, they cause a solute-poor diuresis. The patient loses proportionally more water than sodium.
Leading to water depletion and hypernatremia.
Exactly.
Now, what about nutrition? That seems like a major, maybe sometimes overlooked factor, especially in critical care or step-down units, enteral tube feeds specifically.
Oh, absolutely. They are a persistent culprit.
Yep.
Many enteral formulas are quite concentrated, hypertonic really. And if they're given without specific mandated supplemental free water flushes, just pushing the formula, they create this osmotic load.
Right.
This results in an osmotic diuresis. Water just follows the solutes out, leading to rapid free water loss and potentially precipitating hypernatremia quite quickly. This is a crucial nursing and prescribing protocol point we absolutely have to reinforce. Free water flushes are not optional.
Good point. And then finally, there's the direct sodium gain. You mentioned this contributes to, what, over half of hospital-acquired cases?
Yes, over half. Here, we're actually adding too much salt, usually in a hypertonic vehicle.
So the truly iatrogenic causes.
These are the ones we really cause ourselves. Hypertonic infusions.
Yeah.
We're talking about large volumes of hypertonic saline, maybe for treating severe hyponatremia or elevated intracranial pressure.
Yeah.
Or generous use of sodium bicarbonate during metabolic acidosis. Even some sodium-heavy antibiotic preparations given frequently can contribute.
Okay.
In these cases, the patient's total body water volume might actually be stable or even increased, but the total sodium load is just shot up disproportionately, leading straight to hypernatremia.
So whether it's that pure water loss picture or the excessive sodium gain, the underlying vulnerabilities, often the patient's dependence on staff, may be coupled with suboptimal monitoring. That makes these patients really susceptible.
It really creates a dependency loop. If a patient can't communicate well or has altered mental status, maintaining euvolemia and eunatremia falls entirely on the medical team. It just highlights the systemic risk that's inherent in our current processes sometimes.
Okay, moving on to diagnosis. The clinical presentation seems dominated by the neurologic fallout from that cellular dehydration. As water shifts out of the brain cells into the hypertonic plasma, the brain literally shrinks. What does that look like clinically? What should we be looking for?
Well, we have to maintain a really high index of suspicion and focus on the central nervous system. The spectrum can range from quite subtle changes, maybe mild lethargy, restlessness, agitation.
Things easily missed or attributed to something else.
Exactly. To the more cardinal signs like clear altered mental status, confusion, overt delirium. And as sodium levels climb, say above 160 millimoles per liter, somnolence can progress really rapidly to coma.
And the speed of that elevation is critical too, not just the absolute number, right? What's the immediate, maybe catastrophic risk if the sodium shoots up very quickly?
The primary mechanical risk is hemorrhagic. That rapid brain shrinkage puts tension on those delicate bridging veins connecting the cortex to the dura. That stretching can lead to rupture, causing subarachnoid or subdural hemorrhage. In severe acute cases, it might present dramatically as seizures or focal neurological deficits. And we really can't rely on thirst as a sign, particularly in our high-risk, cognitively impaired patients. They often don't feel it or can't express it.
Right. So once we suspect hypernatremia based on labs or clinical signs, the initial assessment needs a really meticulous evaluation of volume status, because that dictates the immediate choice of replacement fluid, doesn't it? How do we quickly, even if imperfectly, categorize the patient? Are they hypovolemic, euvolemic, or hypervolemic?
Volume status is absolutely essential, but admittedly can be challenging at the bedside. We rely on the standard clinical clues. For hypovolemia, we're looking for orthostatic hypotension, though, that can be blunted in the elderly.
True.
Along with maybe more subtle signs like tachycardia, dry oral mucosa, decreased skin turgor. Hypervolemia is usually a bit easier to spot.
Yeah.
JVD, edema, pulmonary congestion.
And euvolemic.
Euvolemic cases are typically those with pure water loss, like maybe diabetes insipidus, or perhaps resolved water deficits where the sodium level just hasn't normalized yet.
Got it. Let's talk about the lab workup. Beyond the basic serum electrolytes, BUN, creatinine, glucose, osmolality, those are mandatory. But you mentioned a clinical clue involving the urea to creatinine ratio that could be highly sensitive and specific. Let's dig into that.
Yes, this can be a practical, quick diagnostic tool right at the bedside. We look at the calculated urea to creatinine ratio. A ratio greater than 57 is highly suggestive of hypovolemia, specifically in the setting of hypernatremia.
Okay, greater than 57. Why does that ratio reliably point towards hypovolemia? What's the physiology?
It really comes down to renal dynamics. When a patient is volume depleted, the kidney tries fiercely to conserve both water and sodium.
Right.
This state of hypoperfusion, driven by that effective circulating volume depletion, triggers enhanced reabsorption of both urea and sodium way up in the proximal tubule. Creatinine, however, is mostly just excreted, so its level doesn't rise proportionally to the urea.
Ah, I see.
So that rising urea relative to a more stable creatinine level signals pre-renal azotemia, which is basically our physiological signature for volume depletion. It's a great bedside tool, provided, of course, the patient doesn't have underlying CKD or other conditions like a GI bleed, which would independently raise the BUN and throw off the ratio.
That context is vital, recognizing when the tool might be misleading. But the real diagnostic linchpin, the thing that helps differentiate the source of the water loss, remains the interpretation of the urine osmolality.
Absolutely. The urine osmolality is our window into whether the kidney is doing its job properly. It tells us if the kidney is maximally concentrating the urine, which is the appropriate physiological response when the serum sodium is high.
So what are the two main patterns we look for in the urine osmolality, and what do they tell us?
Okay, the first pattern is the expected physiological one.
Oh.
A high urine osmolality, specifically greater than, say, 800 millismoles per kilogram. Osmolality, DU, PGU.
Okay, high concentration.
Right. This suggests the renal concentrating ability is intact. It means the pituitary is likely secreting AVP, and the kidney tubules are responding appropriately. The hypernatremia in this scenario must be due to extrarenal water loss. Things like insensible losses from fever or tachypnea, maybe significant GI losses like osmotic diarrhea, or simply not enough water intake. The kidney is doing its best to conserve water maximally.
And conversely, what if the urine osmolality is low? Maybe less than 700 milliosmoles per kilogram, perhaps even much lower, getting down towards plasma osmolality levels.
Well, that suggests a renal water loss problem. That pattern points strongly toward diabetes insipidus, either central DI, meaning a failure to produce AVP, or nephrogenic DI, where the kidney tubules fail to respond to the AVP that's present.
Okay.
However, we also have to consider osmotic diuresis in this situation. That is, the presence of some non-reabsorbed solute that's basically pulling water out with it. Classic examples are severe hyperglycemia, the glucose acts as an osmotic agent, or high doses of mannitol, or maybe profound urea retention.
And differentiating between GI and osmotic diuresis is critical because the management is completely different.
Totally different. One needs hormone replacement, the other needs the osmotic agent removed or treated. So that urine osmolality combined with urine electrolytes and maybe urine glucose really helps sort that out.
This fundamental lab differentiation really drives the entire subsequent management plan. So let's transition now into the evidence-based management strategies, emphasizing the steps that have to follow this differential diagnosis. What's principle one?
Principle one, and it's surprising how often this gets overlooked in the rush to just correct the sodium number, is treat the underlying cause.
Seems obvious, but yeah.
Right. If the patient's on loop diuretics and is euvolemic or maybe even slightly hypovolemic, stop the diuretic. If they're getting those hypertonic enteral feeds, adjust the formula and implement the required free water flushes. If you diagnose central DI, start desmopressin, simply pouring in hypotonic fluids without removing the underlying driver. Well, it's like bailing a leaky boat without plugging the hole.
Makes sense. Okay, principle two then addresses volume status and dictates that initial fluid choice. How do we manage the patient who is both hypernatremic and hypovolemic with hemodynamic compromise? Like they're in shock.
Right. If the patient is clinically in shock or severely hypotensive, meaning true hemodynamic instability, the absolute immediate priority is restoring that intravascular volume.
Okay.
In this specific scenario, we temporarily set aside the hypernatremia focus and initiate isotonic saline 0.9% sodium chloride. This expands the circulating volume quickly and relatively safely.
But there's a vital caveat here, isn't there? Isotonic saline, while right for shock, still contains 154 millimoles per liter of sodium. So if the patient's current sodium is, say, 155, it's effectively hypotonic relative to them. But if their sodium is 165 or higher, isotonic saline is still relatively hypotonic, but not very hypotonic. How do we manage that transition away from normal saline?
That's the critical pivot point. Isotonic saline is for hemodynamic stabilization only. Once the patient is stable out of shock, volume status improved, we must immediately transition to truly hypotonic fluids to address the free water deficit itself.
Why? What's the risk of continuing isotonic fluids too long?
If we continue isotonic fluids unnecessarily, we risk exacerbating hypervolemia and causing volume overload, especially in patients with underlying cardiac dysfunction. We've fixed the shock, now we need to fix the sodium and the water deficit.
Okay, so once volume is stabilized, we move to principle 3. Quantifying and replacing that free water deficit. You mentioned calculation of the deficit is strongly recommended to guide therapy.
Yes, we generally rely on the established formula for the estimated water deficit. That's water deficit in liters equals total body water times the fraction serum sodium divided by 140 minus 1.
Right, and total body water, TBW, is estimated.
Typically estimated as about 0.6 times body weight in kilograms for men and 0.5 times body weight in kilograms for women. This calculation gives us a target volume, the amount of water needed to bring the sodium back down to 140 millimoles per liter.
But this formula, it's standard, but it relies heavily on that fixed TBW percentage. How accurate are those percentages in a real-world hospital setting with diverse patients?
Yeah, that's where the nuance of clinical practice really comes in. The formula is a useful starting point, definitely, but it's only an estimate.
Right.
Those 0.6 and 0.5 factors assume a kind of average body composition. For patients who are significantly obese, their TBW is proportionally lower relative to total body weight because adipose tissue holds much less water than muscle.
Makes sense.
Conversely, for someone who is perhaps cachectic or has severe ascites, their TBW percentage might be skewed the other way. So we absolutely must treat the formula result as a guide, not a rigid prescription. And we have to rely heavily on continuous clinical and laboratory monitoring to adjust the therapy.
Constant vigilance. So once we have that estimated volume deficit, what are the main fluid replacement options? What are the go-to hypotonic fluids, and are there specific considerations for each?
The goal is hypotonic fluid administration, always tailored to the patient's volume status and any ongoing losses like diarrhea or urine output. The preferred route, if the gut works and the patient is conscious and can drink, is always enteral water.
Safest, most physiologic.
Exactly. If we need intravenous fluids, the options generally narrow down to 5% dextrose in water or D5W, half normal saline, 0.45% sodium chloride, or sometimes even quarter normal saline, 0.2% sodium chloride.
And D5W is essentially pure free water, correct?
That's right. The 5% dextrose gets metabolized pretty quickly by the body, leaving only free water behind to enter the cells and dilute the sodium. It's the most direct way to correct a pure free water deficit. But D5W carries a risk of hyperglycemia, particularly in patients who are diabetic or just under significant physiological stress. We have to watch the glucose closely.
And half normal saline.
If the patient still has some mild hypovolemia but is hemodynamically stable, 0.45% sodium chloride is offered a good choice. It provides 77 millimoles per liter of sodium and chloride, but also 77 millimoles per liter equivalent of free water per liter given. This blend helps prevent an overly rapid drop in sodium while still providing the necessary water for correction.
Okay, this fluid choice is obviously intertwined with maybe the most critical decision point, the rate of correction, and this seems to be governed entirely by the estimated chronicity of the hypernatremia. This is where we get into the difference between safe correction and potentially catastrophic cerebral edema.
This is absolutely where we need clinical precision and, frankly, a zero-tolerance approach to misclassification. For chronic hypernatremia defined as lasting longer than 48 hours, or, much more commonly, when the duration is simply unknown.
Which is often the case.
Very often. The standard recommendation is an exceptionally slow correction rate. This is absolutely necessary because over time, the brain cells have adapted to that chronic hypertonic environment. They do this by synthesizing and accumulating internal solids, called idiogenic osmolytes, to balance the osmotic pressure.
Okay, so the brain cells have protected themselves by increasing their internal osmolality, and if we drop the plasma sodium too quickly in that chronic state,
we reverse the osmotic gradient far too rapidly. Water rushes back into those brain cells trying to equilibrate with the retained osmolytes. This leads to cellular swelling, cerebral edema, and potentially fatal brain herniation.
A disaster.
A complete disaster. Therefore, for chronic cases, or cases where chronicity is unknown, the hard limit must be respected. The correction rate should be less than or equal to 10 to 12 millimoles per liter per day.
Which translates to?
That translates to a rate of less than or equal to 0.5 millimoles per liter per hour, max. This slow rate gives the brain the time it needs to safely dissipate those accumulated osmolytes as the plasma tonicity gradually comes down.
Okay, zero point 0.5 millimoles per liter per hour for chronic or unknown duration. Now let's pivot to acute hypernatremia. This seems to be where clinical practice and maybe the evidence base are evolving, particularly for those iatrogenic cases like massive sodium overload.
Yes, this is a very different scenario. And applying the slow chronic rule here doesn't just not apply, it can actually be harmful. If the duration is clearly less than 48 hours, say, a patient got a huge load of hypertonic saline in the OR yesterday.
Right, a known acute event.
Exactly. The brain hasn't had time to synthesize those protective osmolytes. So the danger here shifts away from cerebral edema caused by correction and more towards the risks associated with prolonged severe hypernatremia itself, risks like cerebral hemorrhage, seizures, profound catabolic states.
So for true, documented acute hypernatremia, faster correction is appropriate and maybe even safer. What does the latest data like meta-analyses suggest about the maximum safe rate in these acute scenarios?
Recent data strongly supports that for these acute, often sodium overload cases, correction rates up to 1 millimole per liter per hour seem not only safe, as major neurological complications like edema were rarely reported below this threshold in acute settings.
Okay, up to 1 millimole per liter per hour.
Yes, but they're also associated with lower overall mortality, especially if the sodium is corrected relatively quickly, say within the first 24 hours.
That's double the rate of the chronic threshold. Why is understanding this difference so absolutely crucial for a hospitalist?
Because misclassification is the source of potentially catastrophic error. If you treat acute sodium overload too slowly, using the chronic rule, you prolong the period of extreme hypertonicity. You expose the patient to the high intrinsic morbidity and mortality risks of the severe hypernatremia itself. Conversely, if you mistakenly treat a chronic free water deficit too fast, using an acute protocol, you almost guarantee cerebral edema. So our first clinical duty is to determine chronicity. That usually requires meticulous chart review, detailed history from family or transferring facilities, and the key takeaway, when in doubt, always assume chronic and correct slowly.
Assume chronic if unsure. That's a critical safety principle. Okay, let's move to the fourth pillar of management, monitoring. Given that thin margin for error, especially between the 0.5 and 1 millimole per liter per hour, targets depending on chronicity, vigilant, frequent monitoring seems mandatory.
It is. And it's arguably the single biggest logistical challenge in managing these patients safely. It's often cited as the weak link in hospital protocols. Suboptimal management, delayed recognition of the problems, these are often direct consequences of just inadequate monitoring frequency.
So what frequency do the sources typically recommend for checking serum sodium during active correction? And what does that mean practically on the ward or in the ICU?
During the active phase of fluid administration, especially when the sodium is quite high or changing rapidly, serum sodium must be measured every 2 to 4 hours.
Every 2 to 4 hours.
Yes. This is really an ICU or high acuity standard of care, and it demands constant attention and adjustment. If you see the sodium dropping too quickly, say, it drops 4 millimoles per liter in just 4 hours, putting you on track for 24 in a day, you have to immediately react. Have the infusion rate, switch to a less hypotonic fluid, whatever it takes to avoid blowing past that 10-12 millimoles per liter per day limit in chronic cases, or even the faster limit if appropriate.
So very dynamic management.
Extremely dynamic. Once the patient is stable and the sodium is dropping predictably and slowly, then maybe we can back off to checking every 4 to 6 hours.
And beyond just the sodium, what other labs need frequent checks during this process?
We need daily, or sometimes even more frequent, monitoring of potassium. Rapid volume shifts can definitely affect potassium levels. Also chloride, renal function, BUN and creatinine, and blood glucose, especially if using D5W. We have to make sure we're not creating other electrolyte problems or worsening hyperglycemia while fixing the sodium.
And the clinical side of monitoring is just as critical, right? It's not just about the lab values on the screen.
Absolutely not. We must be continuously assessing neurological status. Any deterioration at all, a new headache, increasing lethargy, confusion worsening, or, God forbid, seizure activity must be treated as a potential sign of cerebral edema.
And the immediate action.
Immediate action is stop the hypotonic fluids and potentially consider administering a small amount of hypertonic saline to acutely raise the serum osmolality and pull water back out of the brain cells temporarily. We also need to closely track volume status. Strict inputs and outputs, daily weights as possible, and frequent vital signs looking for tachycardia, hypotension, or signs of volume overload, especially in vulnerable patients like those with heart failure.
Let's talk a bit more about the risks and prognosis. Starting with the risks inherent in the disorder itself. We established the high mortality, 30–40%. What else?
Well, the disorder itself carries that risk of cerebral hemorrhage we mentioned, particularly in acute severe cases where sodium goes above maybe 160 millimoles per liter. But even in chronic cases, prolonged hypernatremia is quite catabolic. It impairs muscle function, immune response, overall organ perfusion seems to suffer. This prolonged state of illness is likely what drives much of the high short-term mortality.
And then we circle back to that primary iatrogenic risk, cerebral edema from overcorrection in chronic disease. Why is that 10-12 millimoles per liter per day limit so absolutely non-negotiable in that specific cohort?
Because the damage caused by rapid overcorrection is often irreversible and utterly catastrophic. Remember, the accumulation of those protective osmolality in the brain takes days. Reversing that osmotic gradient in just a matter of hours results in rapid cerebral swelling, leading to seizures, herniation, permanent neurological damage, and often death. It is arguably the single most important error a physician can make when treating chronic hypernatremia. We just cannot exceed that slow rate.
And conversely, what are the other iatrogenic risks associated with management, besides correcting too fast?
Primarily, it's volume mismanagement. The inappropriate continuation of isotonic saline long after volume restoration can lead to dangerous volume overload, pulmonary edema, worsening ascites, and subsequent cardiac strain. That can be really difficult to manage, especially in an ICU setting.
Right.
Furthermore, the inadvertent use of sodium-rich solutions, maybe certain antibiotics dissolved in saline, or continued sodium bicarbonate infusions can actually worsen the very hypernatremia we're trying to treat. It requires constant vigilance and reconciliation of all fluid and medication inputs.
Good point about reconciling everything going in. Finally, let's consider the prognosis and those long-term functional outcomes. They really underscore the urgency of early and effective intervention, don't they?
They really do. Hypernatremia isn't just a complication of illness. It's a strong, independent predictor of high short-term and long-term mortality. And moreover, delayed correction where the hypernatremia persists beyond, say, the third day of hospitalization that's robustly associated with significantly worse outcomes. It means our window for really effective, impactful care is quite narrow.
And for those patients who do survive this sentinel event, what does their functional outlook typically look like?
Functional decline is exceptionally common, unfortunately. Survivors frequently face a severe loss of independence. The data clearly show that many patients, particularly older adults, end up requiring new residential care placement upon discharge. They don't make it back home. It really demonstrates that hypernatremia often marks this kind of watershed moment of severe systemic decline in an already vulnerable patient population. And our failure to manage it optimally can result in lasting, significant morbidity.
That really brings us back to the central challenge we face daily, doesn't it? Balancing that high risk of mortality from letting severe hypernatremia linger versus the catastrophic risk of cerebral edema if we correct chronic cases too quickly. It really requires sharp clinical acumen to figure out which path to take for each patient.
It absolutely requires meticulous history taking to classify chronicity whenever possible, careful calculation of the deficit, acknowledging its limitations, and, maybe most importantly, that rigorous near real-time monitoring with frequent adjustments. The differentiation between the chronic free water deficit needing that strict 5 millimoles per liter per hour limit and the documented acute sodium overload hypernatremia that might tolerate up to 1 millimole per liter per hour. That is the single most important clinical decision in this whole management pathway.
So, recapping the key takeaways. We've covered the alarming mortality rates, the specific utility of looking at that urea to creatinine ratio for volume status clues, the absolutely critical role of urine osmolality in the differential diagnosis, and the absolute necessity of customizing the correction rate based on known or suspected chronicity.
And we really must conclude by reiterating the critical need for systemic improvement in how we handle this. Suboptimal management remains far too common, often because hospital protocols maybe fail to mandate the required monitoring frequency, or they lack the flexibility to explicitly address these two very distinct clinical scenarios, acute sodium gain versus chronic water loss. They often just give one rate.
Which leads us to our final provocative thought for our listeners. Given the high incidence of often iatrogenic hypernatremia and its truly severe prognosis, and acknowledging that recent evidence strongly suggests faster correction rates, up to that 1 millimole per liter per hour mark can be safe and perhaps beneficial in documented acute sodium overload cases. How should our hospital protocols be standardized? We seem to need protocols that allow for this nuanced, potentially life-saving accelerated correction for the right patient without confusing it with the management of chronic disease and thereby incurring that catastrophic risk of cerebral edema. It really highlights an urgent systemic need, doesn't it, for updated, evidence-based hospital protocols and really rigorous staff education that moves beyond just a single fixed correction rate for everyone.
That's exactly right. It's a necessary systemic focus for improvement across all hospital medicine settings. We need to ensure we're consistently treating the underlying pathophysiology, not just reacting to the sodium number on the lab report.
Couldn't agree more. Thank you for joining us for this crucial deep dive on hypernatremia management.